Hello, everyone. Welcome to our March 2024 webinar series. For our session today, the topic is non-suicidal self-harm and DBT. I see that there are more people trickling in now. We have a good quorum to get started with. So we're gonna do some introduction and also announcing the housekeeping items. My name is Ho-Hui Eileen Wayne. I'm one of the child and adolescent psychiatrists staffing the CAP console line. I also help organize the CAP CME and educational activities along with my wonderful colleagues, Dr. Joan John and Lauren Schumacher. Before we begin, just have a few things to announce. Today's session will be recorded and it will be posted on our website for viewing afterwards. If you have any questions for Dr. Fordwood today, during or after the talk, please use the Q&A feature instead of chat in the webinar, and we will try to save 5 to 10 minutes, answer the questions live if possible. For the interest of time, we're gonna go ahead and introduce our speaker today. It is a pleasure to have our expert, Dr. Fordwood. Dr. Fordwood is a clinical professor in the UCSF Department of Psychiatry and Behavioral Sciences. She received her undergraduate degree from Cornell University, her doctoral degree from UCLA, and completed her internship and postdoctoral training at UCSF. Dr. Fordwood specializes in dialectical behavioral therapy, aka DBT. It's a goal-focused and skills-based treatment that addresses a wide range of emotional and behavioral issues and involves the practice of emotional regulation, distress tolerance, interpersonal effectiveness, and mindfulness skills. She's also trained in cognitive behavioral therapy, CBT, and prolonged exposure therapy, PE, and includes these approaches in her work with high acuity adolescents and young adults and their parents in the UCSF Wavefront DBT program. In addition to providing clinical services, Dr. Fordwood also remains involved in research on delivering evidence-based treatment in clinical settings. She enjoys supervising psychology and psychiatry trainees and teaching about DBT and related topics. With this, let's welcome Dr. Fordwood.
Great, thank you very much. So I have nothing to disclose, and I know, is there anything you want to add about the disclosures?
No.
Okay. Okay. All right. So I have many things to cover today. I was really excited to talk about DBT and about non-suicidal self-injury, and there's a lot. So I will go through these pretty quickly, and hopefully you can get most of the information that you need from the slides if you want to go back to them. So as a result of this training, I would like for folks to be able to conceptualize and assess non-suicidal self-injury from a DBT perspective, know ways to implement means restriction and have some safety planning strategies, know when to refer to DBT and explain to teens and their parents how DBT can help, and be able to inform teens and their parents about DBT resources. So what is DBT? So it was originally, Marsha Linehan was initially a suicide researcher, and she actively recruited the most challenging cases. So folks who were suicidal, self-harming, on inpatient units repeatedly. These were the folks she selected to develop DBT. We think of DBT as being a combination of CBT, cognitive behavior therapy, and Zen Buddhism principles. It's a combination of the two, and it's designed for multi-diagnostic patients. We see BPD, borderline personality disorder, which many of the folks who DBT was designed for originally ended up meeting criteria for BPD. So now DBT is associated with borderline personality disorder. We think of this as emotion, what we'd love it to be called is emotion regulation disorder, because it seems a lot more clear. So we really are looking at addressing emotion dysregulation. Behavioral problems, interpersonal problems, all of these stem from emotion dysregulation. And you can think of DBT as a treatment for that. We teach skills to address skills deficits. The problem behaviors that we see in folks who come to our clinic, including non-suicidal self-injury, are viewed as just not being able to have the skills to effectively cope. And so by teaching skills, we can address those skills deficits and have change in behavior. DBT is not, when I'm talking about DBT in terms of our program here in the Wavefront Clinic, I'm looking at, this is a comprehensive program. So there's multiple components, which we'll talk a little bit about. It's flexible. It's not just following a manual. So we use principles to guide us, and we target each person's specific needs with the skills and support that is most effective for them. And it is time limited. So this is not going to be ongoing forever and ever. We look at stage 1 being 6 to 12 months, and then stage 2 being another 6 to 12 months. There's also DBT for adolescents, which is what our program is. So there's an addition of a family component. There's not that much modification of the skills, although there is a little bit more use of environmental intervention, which it makes sense given the younger age, and treating multi-problem adolescents and their parents. There's a really wonderful video on our website called "What the Heck is DBT?" And that can give you a brief summary of DBT for adolescents and is also helpful to share with teens and their parents. Fair amount of research done on DBT in general, and there's been research on DBT-A, finding it effective for suicidal behaviors as well as non-suicidal self-injury. And these studies are very inclusive. These are not limiting who is coming in very much, and really finding that we can be helpful for treating these high-risk behaviors. There's also DBT-C, developed by Dr. Paraplechikova, and we don't offer this at our clinic. I think it might be a helpful resource for some of the parents that you're working with to check out childdbt.com. There is a parent, it's not taught as a therapy group, it's provided as an educational group, and some links to services about DBT-C can be found at the end. Well, there's only one program at the end. I'll highlight that when we get to DBT resources. When we're talking about DBT, some people think of DBT as just the DBT skills, but it's more comprehensive than that. And our program is focused on stage 1, which is getting the life-threatening behaviors under control and getting skills on board. So decreasing life-threatening behaviors while increasing knowledge and ability to apply different DBT skills. And then we also work with stage 2, where this is more about learning how to experience emotions more fully without becoming suicidal, without engaging or having urges to engage in self-harm behaviors. And this is where trauma work would often happen. We don't start by addressing trauma. We would wait till the skills are on board and people can stay safe before doing most trauma work most of the time. In full model comprehensive DBT, we've got skills groups, we've got individual therapy, we've got family therapy as needed. So every other week, once a month. We have phone coaching. The purpose of phone coaching is for people to be able to call their therapist, or for the parents to be able to call the group leader, so they can get help in the moment to use DBT skills to not engage in target behaviors like non-suicidal self-injury. This is offered 24/7, so our teens and young adults can contact us round the clock and get skills help when it is most needed. This really helps with being able to generalize coping skills rather than just learning about them in the therapy office. We also meet weekly as a consultation team to get support, to get suggestions, so we can stay adherent to the DBT model. And then there's other interventions outside, such as med management, that support DBT therapy. In our treatment hierarchy, it is structured so that life-threatening behaviors are addressed first. Then we would address therapy interfering behaviors, and then pretty much everything else is quality of life. And non-suicidal self-injury is put in the life-threatening behaviors category. Anything that causes tissue damage is put there. So that is a primary target for anyone who is in DBT. We have a lot of different principles that guide our treatment. And in the interest of time, I'm just going to be able to highlight a few of them. So like I said before, this is not a manualized session-by-session program. We use these principles to be able to flexibly apply DBT to each of our clients. The D in DBT stands for dialectics or dialectical. This is balancing different perspectives, allowing opposites to be true, allowing for multiple truths. So how we feel about something can be balanced with how we think about something. Both are valid perspectives. The parent's perspective and the teen perspective, both are allowed to be true. And this is more accurate. It promotes understanding, reduces conflict, gets people unstuck. Another way we can think of dialectical thinking is looking at non-suicidal self-injury. A teen may want to stop engaging in self-harm, and they may also not want to stop because it's helping them in some way. They can see the pros of non-suicidal self-injury and also be able to see the cons. There's truth in all of these perspectives. Behaviorism is the B in DBT. So DBT is a behavioral treatment, and we examine behaviors in detail, really looking at what sets the stage for a target behavior like non-suicidal self-injury, what leads up to it, and then what happens afterwards. What's reinforcing this behavior? Why is it sticking around? So this is our behavioral analysis or functional analysis. We're thinking about what's reinforcing, what are the negative consequences, what is really becoming a behavioral detective, and teaching our teens and young adults to do the same so they can understand their behaviors. And then that also leads us to solution analysis, which I'll talk about in a little bit. There's a biosocial model, nature and kind of biology plus the social environment, that helps explain why some people struggle with emotion dysregulation more than others. And we come back to this over and over again. For some folks in our program, there's more of the biological side. For some, it's more the invalidating environment side. And these two interact, creating, for some folks, having more extreme behavior, extreme emotional responses, maybe responding more quickly, taking a longer time to calm down, and why this happens. All of these things are very validating to be able to explain why folks are experiencing the things they are. And as I said before, problem behaviors are viewed as a result of skills deficits. And this is a non-judgmental way of saying, well, it makes sense that you would be engaging in something like self-harm because that's what you've been doing. You're getting some benefit from it, and you don't have other options that you're finding helpful. Primary dialectic in DBT is this balance of acceptance and change. And this is just throughout the heart of all of DBT. We've got the CBT, cognitive behavior and behaviorism side. On the change side, balanced with the Zen Buddhism principles. On the acceptance side, we are balancing validation, accepting someone for where they're at right now, and also change. So validating, it makes sense that you're engaging in self-injury because it's giving you some emotion regulation, can be more specific for each person. And at the same time, we want to promote and encourage change. So the DBT skills, mindfulness, distress tolerance, emotion regulation, interpersonal effectiveness, are also showing up in this balance of acceptance and change. So borderline personality disorder, here are the DSM-5 criteria in the different areas. So self-dysregulation, emotion dysregulation, behavior dysregulation, interpersonal dysregulation. As I said before, We see the heart of borderline personality disorder being emotion dysregulation, and the other areas of dysregulation stemming from that. We do diagnose BPD in teens. That's never been a restriction in the DSM. And teens and their parents often find this diagnosis validating, as it makes more sense to their experience rather than kind of just depression and anxiety. And then the DBT skill sets map on to each of these areas of dysregulation that form borderline personality disorder. So when we're screening folks for our program, we're looking at these different areas of dysregulation, because then we know these are showing up and we've got the skills to help with it. In DBTA, we also have the middle path skills. So here's more information on what these different skills look like and what they would involve. And again, we're teaching these skills to address skills deficits so we can make behavioral change, decreasing ineffective coping while increasing effective coping. So the take-home message, DBT is a goals-focused, skills-based behavioral treatment. It was developed specifically to address non-suicidal self-injury and suicidal behaviors, folks who are experiencing those. Target behaviors are viewed as a solution to a problem. The problem is often emotion dysregulation. Addressing emotion regulation is central to DBT, and we're going to be teaching skills throughout the way to increase effective coping and decrease ineffective coping. The ultimate goal in DBT is to build a life worth living. So this is not just about decreasing these self-harmful behaviors. It's also about helping people get to the life that they want to have. A little bit about our specific program. We're looking for traits of BPD, one prior suicide attempt, and then a target behavior they are interested in changing, with self-harm being the most common. And we work hard to get a commitment to our treatment. So now we can talk a bit about non-suicidal self-injury. So some definitions here. With non-suicidal self-injury, this is referring to the intentional destruction of body tissue without suicidal intent and for purposes not socially sanctioned. There, by definition, there would not be suicidal intent with non-suicidal self-injury. And sometimes it's not always that clear. And there can be overlap. And so folks can engage in behaviors like cutting, sometimes with no suicidal intent, sometimes there is suicidal intent. And so we're going to be asking about that when we are doing our assessment. And as I said earlier, in DBT, we view non-suicidal self-injury as a life-threatening behavior. And this is addressed at the top of our hierarchy in our individual sessions. And then, in proposed diagnostic criteria for NSSI disorder. So something not currently, we're not diagnosing this currently, and keeping it in mind for the future. So looking at non-suicidal in injury in adolescence, with the average age of onset of 12 to 14 years, rates just under 20% in the general adolescent population and closer to 50% in inpatient populations. Gender differences, if they are found, it's found with girls having higher rates of self-injury than boys, and sometimes depends on what behaviors you are asking about. LGBTQ youth have higher rates of self-injury and also of suicidal behaviors. Some youth will try engaging in self-harm a few times and maybe several times and then stop, whereas others will repeatedly engage in it using multiple methods. It's addressing multiple functions. And these folks are usually at higher risk. And these are more typically the folks that we're seeing in our clinic. And even though self-injury may not have suicidal intent, non-suicidal self-injury is a significant risk factor for suicide attempts. So it can progress. You're also wanting to look out for folks who their self-injury behaviors are getting more severe over time. I'm also more concerned when folks are using substances at the same time they're engaging in self-harm, and what specifically they are doing would also indicate higher risk. So specific behaviors, these are ones that are commonly asked about in screening instruments. So in addition to the more, I think, kind of commonly thought of cutting or burning, asking about hitting and banging yourself, particularly I'm thinking about banging your head, whether that's with your hand or against a wall. Girls are more likely to report cutting, carving into their skin, and severe scratching, whereas boys are more likely to report hitting and banging themselves. The blue that's highlighted, in italics, those behaviors may not be ones that we think of as non-suicidal self-injury, and important to ask about, as it may be, the purpose may be to self-harm. So someone punching a wall out of anger may not be thought of as non-suicidal self-injury, and for the person, it actually is. It's the intention could be to hurt themselves in some way. Thinking about purposely getting into physical fights, or putting yourself in very aggressive situations in sports with the purpose and the intention of getting hurt, though these can also be self-harm behaviors. Again, these are showing up more for boys, and this may get missed if not asked about. So behaviors that happen we're thinking about the functions of non-suicidal self-injury. Behaviors that happen repeatedly are reinforced in some way. They serve a function, they serve a purpose. And if we know the function, then we can better tailor how we intervene. So there's been different numbers of functions and models that have been talked about for non-suicidal self-injury. And kind of the take-home message here is that intrapersonal functions, so affect regulation, are the most common, particularly to avoid or decrease an unwanted emotional state. So this would be like the autonomic negative reinforcement. So you're wanting to get relief, and the self-injury is giving you some relief from that unwanted emotional state. Intrapersonal functions are also more common for the ongoing, repeated, more chronic non-suicidal self-injury compared to interpersonal functions. So interpersonal functions, they still are happening a fair amount, as you can see from results from this meta-analysis. So it's not like they're not happening. It's just overall the take-home message is that emotion regulation is really the most common function of non-suicidal self-injury, and perhaps especially for repeated ongoing NSSI. And this really fits well with the DBT conceptualization of target behaviors, and with DBT's focus on improving emotion regulation in general. And you can get a combination of these functions for each person. And I think especially because you have such a brief amount of time to talk to folks, focusing on the emotion regulation piece is probably just going to be more helpful and less judgmental. Okay, so assessment of non-suicidal self-injury. There's some structured interviews. We use the SITB in our program, and there's some self-report measures, and these are all available and accessible online. You may not have time in your brief sessions or with these kids to do these, and they can still be a helpful resource to get a sense of what to ask. The SITB is a structured interview, talks about suicidal thoughts, suicidal behaviors, thinking about NSSI, and also actions. So it's very, very thorough, and it takes quite a while to go through all of it. So how to ask about non-suicidal self-injury. So just as with suicidal behavior, it's important to directly ask about it using a non-judgmental, matter-of-fact approach. And you can provide psychoed while you're doing your assessment. And this can be very, very validating to teens and also to their parents, communicating that non-suicidal self-injury, it makes sense in some way, often as a way to alleviate distress, providing a distraction from emotional pain, or for some folks, it validates their emotional pain. So you can conceptualize it as a solution to a problem. And it may, in many ways, be actually effective in the short term because it does relieve that distress or provide that distraction or change someone's emotional state. And so you can provide some validation. Well, who doesn't want to feel better? It makes sense if this is helping you feel better that you would be doing this in the short term. And that's the acceptance side. And what changes would we want to make? There are other ways to solve the problem of emotion dysregulation. There are other ways we can manage our emotions. And this is where DBT skills would come in. I wish I had time to talk about all of the DBT skills with you, but I think for non-suicidal self-injury in the moment, focusing on the DBT distress tolerance skills, tip, distract, self-soothe. We don't have time for me to do those skills justice today. And at the end of the talk, in the resources slide, there are some DBT skills videos that were done by folks at Rutgers University, and they are great, brief, really clear and effectively taught intros to these skills. So you can watch them, the teens can watch them, parents can watch them. So that would be it's one of the resources. So the DBT skills, however, that we teach, they may not be as immediately powerful and effective as non-suicidal self-injury at changing the emotional state. And they don't have the longer-term negative consequences. So scars, infection, guilt, shame, judgments from others, conflict, risk of hospitalization, etc. The DBT skills don't have those negative consequences. So that's what we're really going to kind of push for, thinking about a little bit more long-term. If someone in your clinic was engaging in non-suicidal self-injury in the past and they have stopped, we want to reinforce that. We want to praise that. We want to ask what they're doing instead. So what are their current coping skills, and provide a lot of reinforcement for those. You're probably going to get more information if you're asking the teen alone. And there's kind of a dialectic here. You might get more information without the parent present. And then on the other hand, if the parent isn't present, you may later need to inform them, provide that same psychoed over again. So I'm going to have to balance those two. As far as I know, there's no official recommended non-suicidal self-injury screening protocol for primary care. In our DBT initial assessment, we use the SITB, and when we're talking about non-suicidal self-injury, we're looking at these factors here. We've already talked about suicidal behaviors and suicidal ideations. So that's why it's not listed here. And that's something you would want to ask about also because of the overlap. So we want to know about timeline. When did it start? How old were they? How often is it happening? When was the most recent behavior? What exactly are they doing? So what behaviors are they engaging in? Is it cutting? Is it burning? Is it hitting themselves? Is it banging their head? Where on their body? And then the severity of the injury. We want to know what instruments they're using, what tools are they using, and do they still have access to those tools? That's going to be key when we're talking about means restriction. We're Want to know what are the usual precipitants, what prompts them to engage in non-suicidal injury, what's going on at that time. Also for the more severe self-injury or the more recent ones, wanting to know about that, the prompting events. And then the consequences, what happens after? Was medical intervention needed? What happens with their emotions, with their thoughts, the way they think about themselves, interactions with other people? And next steps for the future, how likely is it they'll do it again? And do they want help with stopping? In DBT, we are doing a behavioral chain analysis every single time a target behavior like self-harm happens. So getting, as I said before, really, really specific in terms of the behavior, what leads up to it, the actual behavior, and also the consequences every single time until we can figure out a general pattern. But we're doing this a lot in the beginning of treatment. And we want to really zoom in on the different links. So B is the problem behavior, the target behavior, or the non-suicidal self-injury. That's what we would start with when we're doing our chain analysis. Okay, what actually happened? A are the antecedents. What made you more vulnerable that day? What was the prompting event that set off the chain? What are the links in the chain, the actual behavior, and then the consequences? So a recent chain with working with someone that we went over was vulnerability factors was not eating enough, previous conflict with parent, and some school stress. The prompting event was a comment from their partner. I don't like it when you make sarcastic comments to me. Links in the chain were thoughts like he doesn't care about me, emotions like sadness, physical sensations like a sinking feeling in the stomach, more thoughts, he's going to break up with me, anxiety increases, mind starts racing, more thoughts, why do I always do this? I'm a terrible person. So we would notice the catastrophizing, the self-judgments, the all or nothing thinking. Then we have emotions of guilt rising. The mind starts racing even more. We have panic. I can't tolerate this feeling. It's never going to go away unless I do something. Thinking of a razor in the bathroom, going to get it, and then engaging in the behavior. For consequences happening after, there's a sense of relief. There's that overwhelm calms down, and that's only short term. And then the guilt comes back in, the concern about how partner is going to respond when they find out about this, and a sense of hopelessness is another one of the consequences. So looking at both the positive and the negative consequences of the behavior. So here, more information on the steps of the chain analysis. And one of the purposes of this is understanding. Another purpose of this is to form a solution analysis. And in each of those links of the chain, what are different skills that we could use? What are different ways we could intervene, coming up with a cope ahead or a prevention strategy so we can make changes in the future. For primary care settings, this acronym of STOPS FIRE provides an assessment guide for non-suicidal self-injury and for family medicine and primary care providers. So going through asking about suicidal ideation, the types of behavior, the onset of the behavior, location, severity of damage, the function, the intensity, repetition, and episodic frequency. And then this one also gives some guidelines on when you would refer, how severe this would be comparatively, and some suggestions for interventions. Another assessment tool, the SOARS, was developed to help physicians screen adolescents for non-suicidal self-injury. And they also had some research on a single session didactic curriculum for pediatric residents. So kind of asking similar questions. And in the interest of time, I will really quickly talk about pros and cons. This is one way we can help folks get to their wise mind when they're thinking about, do they want to change this behavior? This helps us determine the function of non-suicidal self-injury or any target behavior and emphasize what the costs are of continuing to do it. This helps us identify obstacles. So the cons of stopping, obstacles to stopping, and then we can address those. And also highlight the benefits of stopping this behavior and doing something different. So we use pros and cons to help increase motivation to change behavior. When possible, in terms of informing parents, we do want parents to know about non-suicidal self-injury, especially if it's recent, chronic, and severe. And you can have this conversation with parents collaboratively with your teen and agreeing together, hey, this is something that's important for your parent to know, and kind of talking through the teens, the pros and cons of not telling the parent. In DBT, we really, really want the parents to know we can't do DBT in our program without a parent being involved. So that's just part of the deal. And we would need their help with accessing treatment, helping with means restriction, and then actually being able to do DBT. Another thing about telling parents is you can address some of the myths. So this is not just something that all teens do. It's not just a phase. It's not just manipulation to get out of things. So thinking about when to refer to DBT, this is what we are looking for to refer folks for our program. Our current wait list is 5 months, and we have 2 newer one very, very new providers on board. And so we're expanding and we're growing, and hopefully we can reduce that waitlist time very, very soon. Non-UCSF DBT programs or programs that are not comprehensive DBT usually have lower criteria for what is required to join our program. We typically do not recommend inpatient units for non-suicidal self-injury, and we use hospitalization as a last resort. And there's some iatrogenic effects of hospitalization that we are concerned about, including increased risk of NSSI, stress and trauma from being in the hospital setting, and then possible reinforcement of these ineffective coping strategies. So you would really want to go through some pros and cons with the teen and their parent. Residential programs also typically not recommended, and we refer to those only when outpatient has not been helpful and there are significant safety concerns. Maybe the parent is not able to keep the child safe, the teen safe, and the teen isn't willing to do more. There are a few recommended DBT programs, the residential programs like Sunrise, which is for teens, and then Clearview, which is 18+. PHP IOPs, these can be very effective ways to have a fair amount intensive treatment in a short amount of time. RISE DBT in the South Bay is one that is a DBT program specifically. Others include DBT skills, but they're not full DBT. In our groups, we don't allow discussion of target behaviors like non-suicidal self-injury. We really keep our skills groups focused on the skills. So this prevents maybe triggering. If someone's talking about self-harm or suicidal behaviors, it could be triggering for others, may inadvertently promote these behaviors. So something to think about when you're referring to programs that have groups that are not DBT skills groups. In terms of safety planning, so teens with BPD traits often experience more intense emotions than their peers. Their emotions may spike more quickly and take a longer time to calm down. So it's even harder for them to not act on their distress. And the suicidal and self-harm behaviors, that's where they usually occur at the top of this distress curve here. So you're going to bring in our ABC model here, and this is where we're going to target Where in the chain do we want to bring in our skills? And if it's possible, in the brief time you have with someone, if you're thinking about the behavior, give them something else to do, refer them to those DBT skills cartoons, and they can apply some of those DBT skills, distress tolerance skills in the moment. In terms of antecedent interventions, how can we restrict access to means? Remind them of their long-term goals, those wise mind reminders. And how can we decrease reinforcement of self-harm and increase reinforcement for effective behaviors? So if a teen is self-harming and then they get to get out of going to school, they get to stay home, parents are very concerned and loving and kind and warm, that may be reinforcing the self-harm behaviors, even if people aren't aware of that. So we would want to have some changes in the consequences. So self-harm is often impulsive. Means restriction, it buys us some time. This is something you can talk about with the teen. This is something you can talk about with the parent. This is a really primary and effective strategy. So what is their preferred method, and is it available, and how can you get rid of it or really just separate the person from the method? If they tend to use razors, then those are out of the bathroom. Maybe they can get permission to use it while they're showering, or maybe not, depending on their ability to not engage in the behavior. We know we can't make it. People can get things. People can go to the store. They could try a different method. But if they have a preferred method, that's going to be their go-to. This gives time for the emotions to calm back down, and maybe they can think it through a little bit. And then also that self-harm object won't serve as a trigger or serve as a prompt if they just see it lying around, if it's just in their room. And if there are highly lethal means around, it's always advised to reduce access to those. So this is a website. There's a link there at the bottom about lock and protect. So this gives parents information on how to restrict access to means. It's included in the resources at the end. But in terms of those highly lethal methods, so if someone is suicidal, talking about gun safety, removing implements for hanging. And then also parents can restrict access to medications, lock up sharps, securely store poisonous household cleaning products. And you can say to parents, I know this is not convenient. You can validate that. This is going to be a lot of effort and work for the whole family. And this is what we need to do right now to help keep your teens safe. So parents can engage in room sweeps. They can take the locks or the doors off the bedroom, have location services on the phone, be very aware of where the car keys are. Lots of great guidelines and tips in this Lock and Protect website, which will walk parents through all of these different areas. Safety plans, different than a kind of a safety contract where you're just signing a paper saying, I'm not going to hurt myself. This is actually going through in a step-by-step way, that whole kind of chain that we talked about. How can I make my environment safer? Reducing access to means. What are the common triggers? What are some skills, some specific things I can do? Who are specific people that I can call? So it's talking about a whole range of behaviors and social support and changing the environment to keep things safer. In DBT, this is the one that I like to use, so it's more specific and has specific links, references to DBT skills. I give a copy to the teen, often to the parent, not always. And then it's helpful for other providers to know as well, especially if you're going on vacation and someone's covering for you. And when someone is in crisis, that's not going to be the time that they can think about what skills can I use when the distress is really high on that emotion chart. So having this already written out, already done, and so they can just refer to it. They can take a picture of it so it's on their phone. There's multiple ways they can always have it with them. And this is kind of a summary of the DBT skills and when you would want to use them in terms of your SUDS, your subjective unit of distress scale. So right at the top, we've got the distress tolerance skills, and those are the ones I would start with when you're checking out the Rutgers University DBT videos. So in terms of DBT resources, there are some local, well, the residential ones aren't local, but local DBTA, most of these are DBT for adolescent resources. So we've got the link to our website, the Wavefront DBT clinic. There's also that's the comprehensive DBT program. So it's the full package deal with the individual, the skills group, the family, the phone coaching, everything. There's also a DBT skills group run by Dr. Rachel Kramer, and she gave me permission to give her email address. So if someone's wanting a skills group only, I think they have to be in therapy with someone, but it doesn't have to be with a DBT therapist. It's my understanding that in Oakland, there's no longer a full DBT program, but there are DBT skills groups and DBT informed care. There's a DBT for adolescents program at Stanford. There's the RISE intensive outpatient program, which I talked about earlier, which is in the South Bay. And we have, our team has provided training and consultation with the San Francisco Department of Public Health, with Seneca, and there's a Spanish DBT there, and then also with Contra Costa County. The private practice DBT programs listed here, for the most part, with they all are providing adherent or mostly adherent DBT, and could be a great resource considering wait lists, and the con is the cost. So that's definitely a limiting factor. And those are the two residential DBT programs that we have found to be helpful for some folks. Sunrise actually spoke at the International DBT conference in November, and they are doing research on their long-term, kind of their immediate results and also their long-term results. And so they're really trying hard to show that they are making effective change. Here's the DBT skills videos link that I've been talking about. Highly recommend that you check those out or offer it to parents and teens who want to learn more about DBT skills. The Lock and Protect website for guidance on means restriction. Family Connections is an online DBT skills group for friends and family it doesn't have to be of someone with borderline personality disorder. It can be friends and family of someone who has emotion dysregulation issues. And I believe these are all free, the Family Connections groups. I don't know what the wait list is like. I had several parents come into our program after already doing that, and they found it really helpful and already knew a lot of the DBT skills. So it's not specifically for parents of teens, it's just for friends and family members in general. Behavioral tech, what is DBT? Information more on what DBT is. It's also on our website, our Wavefront Clinic website, and then University of Washington, where this was developed, more information there. And then Cornell University has a self-injury and recovery resources website, which is very, very thorough, and it's not DBT based, and it provides a lot of really helpful and interesting and practical information on non-suicidal self-injury. In terms of books that are DBT based for addressing non-suicidal self-injury, well, some of them are more general, some of them are more specific to that. Here are 2 books for parents and 2 workbooks for teens about non-suicidal self-injury and some DBT skills as well. And that references here, but then also now I think we have some time for questions.
Thank you so much for the excellent talk, Dr. Forwood. There are some questions in the queue, so let me start pitching them to you. The first question is in the chat from Tina Han. Since most of the wait list is several months long, can you give other possible resources that we can consider then? These were shared in your previous slide. And there are many resources, it seems like, in the Bay Area besides UCSF. Is there one that you like most in the Bay Area?
Well, I think it kind of, sorry, I'm trying to get out of here. So it depends. The Stanford program is great. Dr. Michelle Burke is now running that. I don't know what their wait list is. And the DBT skills group at UCSF, which is just the skills group, that's not going to have as long of a wait list, is my understanding. So that could be a way to even just get started. The private practice programs, they have their wait list varies, but it's very expensive.
Thank you.
The RISE IOP, if someone is, higher acuity and they have the time, that would be a great way to get a lot of the skills in a short amount of time. And they do try to work around school schedules. And other intensive outpatient programs do use a lot of DBT skills, like Mills has a lot of DBT skills in their program, but it's not a specific DBT, a full DBT IOP.
Thank you. So for people who have non-suicidal self-harming, it is still top priority to refer them to DBT, but if there's no available resources, then we can consider some IOP that's offering both CBT and DBT. And on the topic of CBT and DBT, there's another question. I know you covered this in the very beginning of the slides, that how is DBT different from CBT? Maybe you just kind of touch on that.
Yeah, so Marsha Linehan's first book, which 1993 is when it came out, is actually called Cognitive Behavior Therapy for borderline personality disorder. So the original DBT book is actually called CBT for borderline personality disorder. That's how much it's based on CBT. And it's also really different. So Marsha Linehan started with her very behavioral approach and then added in the Zen Buddhism principles, which really are also at the heart. So that's that balance of acceptance and change. You've got cognitive behavior on one side and then Zen Buddhism on the other side, acceptance and change. The emotion regulation skills taught in DBT, a lot of them are going to be really, really similar to CBT, talking about behavioral activation, exposure-based approaches for anxiety, but also for all emotions. So that's the DBT skill of opposite action. So approaching rather than avoiding for anxiety, sharing rather than hiding for shame. So the emotion regulation skills are very much CBT based. The interpersonal effectiveness skills, assertiveness training, those are also in line with CBT, whereas distress tolerance and the mindfulness skills, those are coming more from Zen Buddhism.
Thank you. So DBT is like a advanced version of CBT, including CBT skills and also other types.
It's the both and the dialectic of both of them being true at the same time.
Mm-hmm. And there's another question asking about many kids with neurodevelopmental disorders such as autism, ADHD also have pretty significant emotional dysregulation and self-harm in the context of impulsivity. Is DBT appropriate for them too?
So we have a lot of folks in our program who have ADHD, and mindfulness skills are even more, perhaps even more important, if they can be more important, for folks who are struggling with attention issues. And in terms of autism spectrum, we actually do get a fair number of kiddos who are referred to us for difficulties with emotion regulation. It may look a little bit different than some of our kids who are coming in with more of just kind of a borderline personality disorder lens, and DBT can still be helpful. So it's as I said a couple of times, it's a flexible approach. So when we're looking at someone's chain analysis, what sets the stage, what leads up to the emotion dysregulation, and then targeting specific skills that can be helpful, we can do that with a wide range of presentations. There is I mean, originally, Dr. Lynch was working with Marshall Linehan in DBT, and he created I want to say a version of DBT, but it's a separate treatment called radically open DBT, RODBT, which he describes as for disorders of over control. So this would include autism spectrum, more OCPD, anorexia, and this is for folks who are kind of overly controlled and then have these moments of time when there's like kind of a burst of emotion. And so it's DBT based and it's a different treatment. So that's another possible approach. But in the short answer, yes, we have folks in our clinic with ADHD and with autism spectrum.
That's very helpful to know. And here is the interesting, I think a great question that often teens will refuse help. There's help seeking, help rejecting. So how to best help these teens who decline formal help or things therapy, including DBT?
Yeah, I know. And that's in our program, we spend a long time getting folks committed. So before someone even does stage 1, we do a minimum of 4 sessions, sometimes much longer, of orientation and commitment to try to win that commitment. And we're not always able to do it. So if someone is willing to even get in the door, we can try to win them over. And one of the examples was that 4-sided pros and cons. If they're not even willing to consider that, maybe they would be willing to take a look at some of those other resources, the books and websites. It's not a substitute for treatment. Parents can still help with means restriction. But yeah, it's tough. I would really want to highlight for the teen, kind of one of the strategies in DBT is extending. Well, where is this going to go? Like, is this what you want to keep doing, for the future? How is this going to get in the way of your goals? If someone wants to finish high school, wants to go to college, like, how is this going to get in the way? Are you going to be able to reach your goals and continuing to do these behaviors?
Yeah, that's super helpful. And I think similarly with a lot of things that PCP could face in the clinic, teens refuse medication, teens refuse psychiatry referral. It really takes a lot of just rolling with them and the motivational interviewing.
Yeah.
I think what I've found really helpful is also often teen has such a strong rapport with their PCP, since a lot of these PCP have been seeing them since birth.
Yeah.
If PCP identifies there is non-suicidal self-harm and you should really consider this, that could really be a big change for them too, if it's coming from the PCP. Like, I recommend DBT or I recommend this type of therapy.
Yeah, and keep trying, right? So it may not work in one moment and it may be effective the next time.
Yeah, we just have 2 more minutes and there's still more questions coming in. I'm trying to see if we can wrap all of them up. There's another question, interesting, about asking about substance use, a type of NSSI, and can we use DBT to treat that?
That I haven't, we've thought about eating disorders as a kind of a form of self-harm. Substance abuse, you certainly could conceptualize it that way. And yes, DBT is a treatment choice for substance use. A lot of our kiddos struggle with that. There's some specific skills developed just for substance abuse, so we can incorporate those into our treatment as well.
And the last question is the current UCSF DBT program all in person, or is there any Zoom options?
It is all in person. So it's been all in person for quite a while. And every once in a while, I'll see someone on Zoom and it's all in person.
I guess that's what makes the difference, the interpersonal connection.
It's it just seems a lot more effective and hopefully enjoyable to have someone in the room. The skills groups are definitely a lot more fun in person too.
Thank you so much, Dr. Fordwood, again for your talk, and thank you for everyone's participation. Here's some information for your CME credits and the next webinar in April on the topic of substance use. So please make sure to use this QR code or this link on the left side of the slide, which is also in the chat, so you can collect the CME credit from today.